Welcome to another episode, our podcast episode today. Sandra's going to tell us a little bit about who we have today, and then we'll be getting on and cracking on with some very exciting questions. We're very excited about this particular episode, looking forward to discussing exciting things today. So Sandra, tell us who we have.
So our next guest that we have today has over 40 years experience working in the health service. She's had a very impressive career working at King's and spanning over 25 years in radiography, which is very important for this podcast. She's worked both in safeguarding and in places with people with learning difficulties. She's been a volunteer and she is a member of the Southwark community. She's an external member of the King's LGBTQ+ network. She's a supporter of best practice and has a lot of experience working with Healthcare Commission and also, importantly, writing radiographic policy. We're very excited to have her here today so she can shed some light on what she does and educate our listeners today. Lindsay Batty-Smith, thank you so much for joining us today.
Pleasure.
So, Lindsay, we've had our introduction. We've sort of introduced you to our listeners today. Can you tell us in your own words what it is that you do?
Okay, so what I do, I'm a radiographer. I'm semi-retired. I still work in clinical practice 1 day a week where I do mammography, DEXA scans and plain imaging. I don't do cross-sectional, so that's quite unusual in as much as I never followed that path, but I'm really cool at doing your plain imaging and that kind of thing. I also am a volunteer at King's College Hospital. I'm a Southwark Public Governor and I get up to all sorts of things with board meetings and stuff as a governor. I do other days in the week if they want me to do radiography, but I really want to concentrate on other stuff. And my forensic experience has been an absolutely wonderful career. And I got lots and lots of energy for doing lots of things and forwarding and promoting forensic radiography because it's such a small and niche role and profession. But with all my years of experience, I've been qualified for 49 years. I only added it up the other day, and I did 25 years at King's. So the next question that you had for me was about my journey, which I think I'll blend into the rest of this question, if that's okay. So I was a kid in Suffolk at the age of 18. I always knew I wanted to come to London. I came from a medical family. They all wanted me to study medicine. And I went, oh, no, because in those days it was hell. It was really bad. So I settled on radiography. And when I came first into radiography, it was film, dark rooms, chemical processing, very old equipment. Health and safety really was not what it is in any shape or form now. We lugged around very heavy cassettes. We did heavy manual handling. We had different roles. We had darkroom technicians. We didn't have healthcare assistants and what have you. So I've seen massive changes in the world of radiography since I started in 1975 and the development of roles. So not only did we change completely the way that we image from film to then computerized radiography to then digital radiography has been massive over the years. And then also the increase and changing in roles in radiography. We have healthcare assistants, assistant practitioners. We go up the seniority. And now you become like a consultant, mammographer consultant, ultrasonographer. All those roles are hugely important. I'm a reporting radiographer. That's actually one of the hardest postgrads I ever did, was the reporting qualification, because you have to have such a high standard of knowledge. I had 2 goes at it, but got it, and it was so empowering. I've worked through the usual, going up the career ladder as junior roles, more senior roles. I've also worked about half and half private sector and public sector, so I know things from both sides of the fence. Things can be quite different between the two because of the policies and procedures that are applied in different places. My 25 years at King's really grew my career. I did 15 years in the emergency department, and I think I saw everything. I think I saw everything until there was something that I'd never seen before. So I've seen every type of tragedy in young and old. And that really got my interest into forensics. I was involved with forensics a little bit before, which I'll tell you about in a bit. after 15 years of ED radiography, I then had the amazing success in getting the Safeguarding Adults and Learning Disability lead role at King's. So that was a complete change. But one of the reasons why I got that job was because of my forensic background. And of course, being a diagnostic radiographer, is legal implications on everything. Every image we take is possibly a legal document. Well, it is a legal document. So when it came to safeguarding, they knew that I had dealt with the police. They knew that I knew how to produce an image that would be acceptable in a court of law. And so with all that background, they took a punt because it's very unusual for a radiographer to become a safeguarding lead. And I learned all about the Mental Capacity Act, decision making, powers of attorney, best interests meeting. I led all the best interest meetings or taught people how to do them. So in very difficult circumstances of end of life care, maybe with a learning disability patient, where difficult decisions were being reached with the medical team of whether to continue treatment or not. So I learned so much from that. My forensic background was hugely helpful in that. And we all learned from each other in that kind of thing. My other interest in forensics, my father was a pathologist, so always growing up, we were talking about bits of tissue. We didn't have Sunday lunches that were quite as classical as ever. We had more like Sunday dissections. So I'm really good at carving a chicken. Apologies to the vegans on this who might be listening. But I'm quite good at carving as a result. So I learned a lot from my dad about the circumstances of death and how pathologists got to the causes of death and injury. When I was at King's, I also developed the AM/PM service for children, SPA, NAI. So that was the first really laying down policy and procedure, because it was a bit of a hit and miss affair. And also to learn about the sensitivities around bringing children into a department at a certain time of day, so we didn't upset anybody, but to actually write the protocols for radiographers to be guided by the standard procedures, because those standards are so important when it comes to coroners and the law courts. That if the radiographer gets it wrong, then the case could be blown out, and then a potential perpetrator will be not charged or sufficiently dealt with for potential crime. So the importance of the radiographer's role is absolutely paramount, and having policy and procedure to support that. And IFR worked with the Society of Radiographers to develop those guidelines and protocols, and they have just been republished, the latest ones. I've always had an interest in education and lecturing, and I've done that for many years now. So from teaching nurse request x-rays all the way up to reporting has been really, really thrilling in many, many ways. I've trained hundreds of radiographers over the years, at King's particularly, but everywhere I go, there's always a student hanging around, a student not necessarily radiographic, a student of any variety. I believe in teamwork and collaboration, and furthering the knowledge of forensic radiographers amongst different teams as well. I've always promoted forensics, and everyone I talk to, I try and, if it's appropriate, mention what we do in International Association of Forensic Radiographers and the training and the education and the teamwork that we do. Supporting my forensic work and my radiography, I've been a CHI reviewer. CHI was pre-CQC. I also work for the Healthcare Commission, doing complex radiological complaints. That was a very educational, very stressful role, but it was good, hard work, and none of my cases went to the Ombudsman, so phew. And I've always believed in promoting safe, good practice and role modelling if possible. So that's my journey, really, in a nutshell.
Gosh, sounds like it's been a very, very thrilling journey. And we've been listening to you. It sounds like over the years you've probably seen a lot and experienced a lot over those years, which have probably shaped you as a person. So then I guess my next question to you then would be, how did you find a transition, if that perhaps may be the right word to use, transition going from sort of diagnostic radiography to forensic radiography? How did you find that transition over the years?
Well, being a bog standard radiographer producing plain imaging in the emergency department and all the, as I mentioned before, the legalities around it, and then finding an interest in why do we do this kind of work for a living, really got me. When I was studying for my master's, I particularly focused on why are certain people drawn to certain professions. So linking that into my developing forensic role. So I've been doing forensics for over 25 years, and it started off with the trauma imaging group, and then it became the Association of Forensic Radiographers that then turned into IAFR. Then blending my practical knowledge into then wanting to know why certain people are drawn to this profession made it really, really interesting. And I wanted to tell people and teach people that particular part of welfare. I'm a big supporter of welfare within these kind of roles that we do, because it's not everyone's cup of tea by any stretch of the imagination. And some people might think that they want to do forensics and then are completely put off and they didn't quite realise. And we've got to pick those people out as soon as possible, because it's damaging to them if they do get involved, or in certain circumstances when management don't understand the barriers and boundaries around who should be doing this kind of work, maybe insist on someone doing a post-mortem case when they shouldn't be doing it. And this is all about the guards and safeguards around the kind of role that we do. My practical work in ED lent itself perfectly to quick decision making, doing adapted techniques, which we do all the time in ED. You know, you've got to get your image somehow, and you can't go home and say I'm not doing that because I can't, because you have to do it. And that led brilliantly into forensics when working on the tsunami and the 7/7 in particular. We were dealing with very, very difficult parts of bodies and techniques around identifying from bags of commingled remains and bits of tube train or whatever. We had to use adapted techniques. I also worked on the tertiary phase of the 7/7 with the reconstruction of the bombers themselves. So we were looking to see what position they were in when they detonated the bomb. So were they sitting, standing, leaning over the rucksacks? So we used a lot of adapted techniques that the team and I, Mark Viner, who I know that you've talked to as well, a very, very close friend of mine, a brilliant forensic practitioner. We could then give the imaging that the police and the coroners required. So it's a segue from years and years of practical situations. And let us not forget the people that come with the customer that we are dealing with. So dealing with families, distraught families, people acting out of grief in many different ways, from silence to shouting, and learning coping strategies around that, how it affects us. And I'll come back to the point that, you know, death affects us all. As a society, we're not very good at talking about it. As a society, we avoid talking about death. There's not much on the media to inform people either. So it's about information and gathering a robust service from one modality to another. And as I say, I think it segues very nicely in from my background in ED and trauma and orthopaedics.
Thank you. So, I mean, I guess the next natural question would be, I guess it's two-part really. The first part is, tell us about your experience as a disaster victim identifier. So that's the first bit. And also secondly, I guess, if you're happy to talk about it as well, tell us about what sort of coping mechanisms one must have if they were to be involved in disaster victim identification.
Okay, so my first big job for forensics for IAFR was the tsunami. And I did the repatriations coming into the Fulham mortuary. So it's my first taste ever of real hands-on forensic radiography. I'd never seen anything like it, that these hugely swollen bodies had come back from Indonesia and in that area were hugely swollen because of the drowning, and they were full of formalin as well. So our eyes were burning all the time. And to see that that process from photographing, the police photographing, then the pathologists, opening of the coffins, then the pathologist, the process viewing the body, taking notes, and then the body eventually coming to the radiographers. So we had this hugely important role. And radiographers often feel subservient in teams because sort of traditional patriarchy still exists in certain areas where doctors, rule the roost and radiographers are given the orders. We said that an X-ray request was a request, not an order. But anyway, so we had difficult imaging to do on very large and swollen bodies. And of course, dental radiography. And I'm an old dental radiographer. I forgot to mention that. I did dental radiography always kept my competencies up because I don't mind putting my hands in people's mouths. Some people do. But doing bite wings on hugely swollen bodies was very, very difficult, but we got the results. So I got my first taste of actually touching people that had lost their lives in tragic circumstances of a natural disaster. This is the difference, the different things that we do, natural disasters or terrorist events, or sometimes we do nice forensics with paintings or doing work for the British Museum. But anyway, the tsunami was the first taste of the real thing. So this brings up a lot of feelings, and then that's when I started to get interested in how we cope. So the wounded healer is a concept that I use, and it's a Jungian theory. I'll try and pressy it. So it looks at, particularly in healthcare, why certain people are drawn to certain professions, and that's because of the desire to heal ourselves. And in forensics, it's all about death and mortality. So when we are dealing with dead bodies, we are constantly reminded of our own mortality. And this can be an extremely uncomfortable experience. And then remembering all the people that we've known that have died and in maybe difficult circumstances. And I certainly know several people that I know died in difficult circumstances. So how do we cope? We cope badly by doing all the bad things that you're not meant to do, or we learn to cope well. And good coping mechanisms are about supporting, about delving deeply into our own personal issues. Have we learnt from our mistakes? So we all are born, we all suffer the same death of a first parent, first love, death of a pet. Every single person experiences those same emotional traumas. Have we learnt from the things that we experienced? If we have, we become extremely good practitioners and we are able to pass on our robust knowledge. If we haven't learnt from our mistakes, we are destined to repeat them again over and over. And these kind of behaviours can spill out into the workplace in different ways, with maybe argumentative staff coming in early, going home late, not engaging properly. So I've looked carefully, and I have a whole lecture that I give called The Pain That We Are In, The Pain We Are In. And it just goes through the whole A to Z, and then gives supporting information at the end, because we cannot do our forensics without looking at welfare of our practitioners, because it is so important. There's things like trim training, there are debriefings, there's all sorts of excellent mechanisms that I hope to bring to Anubix, which I'm very excited about working with as well. So that's kind of like the welfare side. I'm also passionate about diversity, equity and inclusion. And certainly in the world of forensics now, we meet families and loved ones of the A to Z of different religions, backgrounds, beliefs, disabilities, all sorts of things. We need to take this into consideration to make us a caring and supportive and dignified service. So that's another one of my passions too.
Absolutely. And then I think you've touched on some very important words there, actually, really dignified, and also being as supportive as you can as people go through what is, quite frankly, a very difficult time for them to have to go through. Now, what do you think the role of postmortem CT has, or postmortem radiography has, in the roles of the family members who are having to deal with, these sometimes quite horrific events?
Again, not being a cross-sectional radiographer, but it's kind of an umbrella looking at my colleagues, my expert colleagues. So the fact of not having to do an invasive post-mortem is hugely central to most families' lives, especially in certain religions. And now with the incredible capabilities of the CT machines and the way you can do angiography and you can do all those different modalities on a body with minimal invasive or zero invasive procedures is an enormous comfort to families. And also the speed with everyone wants answers so quickly. And this happened in the DVI cases that I did, that the press were hounding for answers. They couldn't wait. People can't wait. We're in a digital age where we want the answers yesterday. But in forensic imaging, we don't hurry, and we will not be pressed, and we will not give an answer until we have triangulated our evidence and we can certainly say what had happened to that person or who that person is. But the non-invasive part of the PMCT procedure is a huge step forward. And families can then have the time to get their head around the more dignified side of things, that they're not imagining their loved ones being cut up, or in those awful stories like the Marchioness disaster. I was around when the Marchioness happened and they cut everyone's hands off. I was around when in Bristol they removed body parts from children and found difficulty in finding out where they were. So the public do have a historic memory of these things if pushed to remember. And these are horrific cases that ended up in court, and practices had to change. So I hope that we're at a point now where best practice has removed all those appalling things that happened in the past. And we've moved on, and we involve the family. And also, we never used to, I don't think, involve the family so much. And now they're integral to part of the process and helping them deal with their grief by getting them the correct answers that they need to move forward and to grieve properly.
Thank you. I mean, just from speaking to you now, we can see that you have extensive experience, both as a radiographer and in the post-mortem imaging world. What would you say is your proudest achievement to date?
Oh, well, I lived and worked in New Zealand for a while, a few years ago, and I went off there to do some mammography and live in a different country and see what it was like. And noticed that they knew very, very little about forensic radiography per se. They just didn't know anything at all. So I was in Auckland. I joined the board of the radiographers there, not forensic, and I started to talk about forensic radiography, and they were really excited and knew nothing about it. So then I started doing extensive lectures across the Auckland. Auckland is a massive place for radiography. It's a very spread out place. So I worked in 5 different hospitals there, and in each of them I presented forensic radiography and got great excitement going. And then I lectured on every trauma conference I could get myself into whilst I was there for 3 years. And then I met up with 2 other IAFR radiographic members who were in Australia, Adele and Denise, and we went to a huge conference in Melbourne. And we had our first stall with IFR, a little stall, a little table with all our leaflets and what have you on it. And Denise and I gave a keynote lecture to that conference to 2,000 people about forensic radiography. And from there, we set up the first branch, international branch of Australian and New Zealand forensic radiography, and it is one of our strongest branches today. So I'm very, very pleased with that. It was a real milestone, and to see it go from strength to strength now is incredible. They do amazing training days, so that's one achievement. And the other proud achievement, slightly different, was I was invited to speak in the House of Lords on the Baroness Stern report about rape, and that was to do with my safeguarding role at King's and how we supported people with learning disability and sexual assault. So going to speak in the House of Lords was absolutely terrifying, but I did it. And looking back, I thought, cool. So yeah, those are 2 that stand out to me.
Amazing. Part of the purpose of this podcast is to demystify forensic imaging, post-mortem imaging, what happens to loved ones' bodies. Would you mind telling us what you think is a common misconception about your job?
Oh, yes. Well, radiographers. Most people maybe I'm a little bit cynical over the years, but think that a radiographer mends radios or does something like that. The public really don't know really what a radiographer is, but when you say x-rays, everyone knows what that is. So the role of the radiographer is still quite an unknown thing. It's, again, not featured much in soap operas or anything like that. So radiographers, and also the word imaging is much more commonly used now. So imaging tech, I don't know, but radiographers, we like that term. But I think the general public don't really know what we do. I can give you an example of that. As a governor at King's, they were putting out a new patient information pack, and they put everyone's uniform in there, bar a radiographer. And I went, oh, excuse me, you need to put the radiographer's uniform in. And they said, oh, well, you don't really go to the wards much, do you? And I went, oh, excuse me, we spend our life on the ward. And also more so than a physio, more so than a speech and language therapist. They had everyone's uniform in there. So a great educational piece was done for the board, and now we're having the radiographer's uniform put into the information pack for patients, because that's where it all starts. You know, I come in X-ray every day. If I'm doing ITU, I might come twice a day. And I've got an identity, and I'm highly skilled. You know, it's been hard work. I came in as a diploma radiographer, and now I've got a degree. You know, I had to do all that in postgrad. So I'm a highly qualified and experienced person that the public know very little about. So when you're coming into post-mortem work, then the public may see us as, again, not quite understanding what we do. So I think there's a big promotion part to be done. But also as individuals, wherever we go, explain what you do. My name is, I am A, this is what I do. And also to really focus on compassion in post-mortem work. Again, I feel very, very strongly about acts of kindness, small acts of kindness, being compassionate, being empathic, not sympathetic, but being empathic. Drawing on your own experience of how you dealt with horror and death, and helping someone, a family member or another colleague, if they're having, you can see that they're not coping so well. Sometimes it's just the fact of having a cup of tea with someone. That can be just as supportive as having a formal debrief. So it's like reading the room properly. Also knowing your boundaries is hugely important. Don't cross your boundaries into other areas of expertise that you don't know about, and don't pretend to. Be an expert in your own area, and keep these ear holes open to learn and create this great teamwork. So we're a combination of all our strengths become a whole. That's how I see it.
Wonderful. And I think it is very important, as you say, that you are represented. And, you know, if imaging comes to a standstill, I would argue so does the hospital. So
the heartbeat. Imaging is the heartbeat. I keep telling people it's the heartbeat of any hospital. Radiology is the heart of a hospital, and without it, you are nothing.
Exactly. And then really last question is, what do you see as the future for post-mortem imaging, or this space in forensic imaging?
Well, I think it's hugely, hugely important, and it's now a whole avenue that's opened up with this around the sensitivities of death, traumatic deaths, high-profile deaths, terrorism, that now post-mortem CT is in a world of its own. And just touching back onto Anubix, the team of people that are being brought together are absolute experts in their own fields. And the potential for this is huge and exciting. And also to bring in such a compassionate and dignified strength to the world of post-mortem CT with the experts that you have with you. I think that Anubix is going to be a leader in this field. I don't think there's anything quite like it at the moment. And as I say, to bring all these amazing professionals, many of whom have this IAFR background. So we've trained, we do webinars. I've been on lots of educational stuff, that I know the people I'm working with. I trust the people that I'm working with. They are highly skilled, they're hugely qualified, and they can deliver a service that is much, much needed and is in its almost embryonic stage, I would think. But you have such a massive experts coming together, that this is a really, really exciting part for post-mortem imaging and the future of looking after people in their most vulnerable states, and people trusting us to be able to help them, and to help them after the event as well, signpost into the correct services that will support them healing from the inevitable. I also bring in my experience from, as a governor, I sit on the end-of-life care and bereavement committees and steering committees. So I'm always talking to the morticians and to see how we're delivering end-of-life care services. So I'm looking at the bit before the person goes to the mortuary. And that's been hugely valuable in shaping up what we can provide and what we can do before that event happens, and then being involved with the post-mortem side of things. How does that segue into that, and how do we make it a seamless service, making sure people have knowledge about their rights, how we can help, how we can support them into a new future.
Cool. And then I guess then the next thing we'll hopefully get to see when we'll be the House of Lords again, giving another talk there, maybe in the not too distant future.
I doubt it.
We're manifesting it here. So thank you so much for your time. We have thoroughly enjoyed this discussion with you today. We've learned a lot about your experience, about how you've gone from doing diagnostic radiography to becoming a disaster victim identifier, working through some quite horrific events that have happened in the past. And most importantly, it's really nice to hear about what you're doing in terms of safeguarding with kids, and also to see all the things that you've done, amazing things that you've done at King's College Hospital as well too. So we are very, very privileged and honoured that you were able to spend your time with us today. We hope our listeners have enjoyed this discussion today as well, and have also learned a lot from this. So this may be the end of our conversation today with Lindsay, but it's certainly not the end of the discussion surrounding what matters beyond death.